welcome to the MedWire News podcast. This is the second of a two-part edition in which we're talking to registered nurse and certified diabetes educator Lori Berard about insulin treatment in patients with type 2 diabetes. In the first part, Lori talked about starting patients on insulin. Here she considers how best to proceed after that first prescription has been written.
Optimizing insulin therapy is really a two-part process. First of all, being able to start insulin therapy, getting over that initial hurdle, and writing the prescription. But we also understand that it's difficult for healthcare professionals is what next? So what do I do after I've started the first dose of insulin? We know that insulin dosages need to be individualized to each person, but how we get there is a little less clear. Over the course of the last 10 to 15 years, there's been a lot of papers published about treat-to-target strategies, self-titration of insulin, starting low and going slow. And I think for our healthcare professionals, there isn't a clear-cut path for them. What we need to do is we really need to encourage healthcare professionals to work collaboratively with the patient to figure out how they can best move their dose to the dose the patient is going to require. Some healthcare professionals really want to be in control of the titration. Others are very comfortable in engaging their patients in doing self-titration. I think it's important to figure out what you want to do in your practice, how you want to work with your patients, how you are going to support your patients in terms of moving their insulin dose, and then informing them. This is approximately how much insulin you're going to need. This is how long it might take us to get there. And never lose sight of insulin titration each time that you see the patient. Make sure that it's occurring, because often other problems come up in the diabetes-related visit and the insulin dose goes unchanged.
What concerns do patients have that can get in the way of them achieving the optimal insulin dose?
For people who are using insulin to manage their diabetes, there's often some barriers to increasing the dose. The concept that the higher the dose, the more serious the disease. So that's how they feel. They feel like, oh, I'm on so much insulin that I must have the worst kind of diabetes. Or also the idea that they're always tuning up their dose means that they're not ever getting to the level of control that they want to be. So that becomes very frustrating, and it also can cause some fatigue or lack of interest in their diabetes management. The other issue that really occurs is that there can be the associated barrier of thinking how expensive it is. The more I take, the more expensive it is. And those are again conversations that we need to have. But I think what we understand from some recent work that's been done is that people living with type 2 diabetes really want to know what dose they might expect, because they don't understand that their neighbor's on 20 and they might need 60 units at bedtime. So just giving them some idea of how much insulin they could be on. And also having the conversation with people that everybody's insulin tank is at a different level. So we top up everybody's tank with what they need, and there's no magic recipe. There is no magic fill line for any one particular person, so that we individualize how much insulin that they need. But I think probably the most important conversation that we have with people, that increasing their insulin dose does not mean that their disease is getting worse. All we're doing is using their individualized dose to get them to their individualized target to prevent the progression of complications.
What advice is available for doctors titrating their patients' insulin?
We've done a lot of work in the past 2 decades in helping healthcare professionals to write the initial insulin dose prescription. Now we have a responsibility to moving to helping them write an adequate titration schedule for their patients. And I think one of the things that's been very promising about that is many countries have actually had suggestions within their national guidelines on starting doses and preferred titration algorithms. And so disseminating the local guidelines that have that guidance in them can be very helpful. I think the idea of keeping it simple and straightforward, but in keeping with the product monographed, especially with the newer basal insulins that have come out, some of the titration algorithms that have been tried and true with basal insulin, such as NPH or insulin glargine or insulin detamere, may not have been tested yet in insulin glargine U300 or insulin degludec. And we shouldn't necessarily assume that we can just move all titration schedules to the newer insulins. So there will become pragmatic real-world studies that help us to embrace simpler titration schedules. But I think the biggest thing that we need to do is help people understand that you do not need to up-titrate insulin overnight, that we can do it slow and steady, but that we should develop some sort of a routine that we're doing it either once a week, twice a week, or every day, and that we can go up by as little as 1 unit at a time or 2 units every 2 days, so that they're feeling comfortable that they're not putting their patient at risk of hypoglycemia. So little taglines that help people to think about, 2 every 2 days, 3 every 3 days, based on the fasting blood sugar, and sometimes it's a single unit every day if the evidence exists. But keeping the message simple, not making people think that they have to take large increases. Oh, I have to double the dose. I have to go up by 8 units. The fear factor for the healthcare professional in big increases of insulin are truly there in terms of they're fearful of causing hypoglycemia in their patient. So reassurance and straightforward guidance, and look at your national guidelines to see if there's any practical recommendations there.
And how can doctors get support on a day-to-day basis?
Worldwide, we understand that diabetes is becoming an epidemic. Type 2 diabetes is becoming an epidemic. And we also recognize that we are not starting insulin as early as we should. And one of the reasons is that we're not sure who can help us. I think it's important to take a look around in your practice and figure out who can help you in terms of managing your patients that you start on insulin. And in many cases, there is a practice nurse that can certainly help with the support. And sometimes the support that a patient needs is just affirmation that they're making the right decisions, or just having the weekly telephone call with the patient to make sure that they are up-titrating their insulin, and that there's a discussion with the prescriber to make sure that everybody's on track. So using the resources that you have in your own practice. If you don't have any resources in your own practice, then you can take a look around. And for many countries, pharmacists are now taking a very active role in supporting patients in their diabetes journey. So perhaps there's a local pharmacist who is helpful in having the insulin conversation and works with the patient to support them. Often there are diabetes education programs or diabetes education centers around you that you can refer your patients to. And what we're really looking for is someone that just continues to support them and helps them to feel like they're on the right track. And it might be that you move to technology. So we might take away the human factor, because there are certainly now insulin adjustment apps, there are meters that help with self-titration, and you as a healthcare professional can program those meters or those apps so that the patients are getting interactive support in a technology-based fashion, and we know that the literature supports that. So while we'll always welcome the human touch in terms of the support for insulin therapy, we can think outside of the box and think about whether technology plays a role in managing our patients.
So once patients have started on insulin, what assessments are important to make sure they're getting the best dose?
As we are starting to move patients along in terms of titrating or advancing their insulin therapy, there are a few things that we should consider, or assessments that we should make. How comfortable are they with doing the self-titration? What are we asking patients to do in order to do effective self-titration of insulin? So obviously we need to have some self-monitoring of blood glucose to be able to safely increase insulin dosages. And over the course of time, we've really talked about basal insulin needing at least one self-monitoring blood glucose test per day to be able to safely titrate. But I think we have to sometimes take a look at the big picture and make sure that we have a safe bedtime blood sugar level when we're giving an insulin dose at bedtime, and that we're looking at the effect the next morning. So we have to use self-monitoring of blood glucose effectively to make sure that we are titrating the insulin appropriately. For example, if we are getting close to a fasting blood sugar that's at our target level, but the A1C is still elevated, it's time to take a look at postprandial glucose control. So blood glucose monitoring is part of it, but keeping it simple for the patient and for the prescriber is very important. So not adding in a whole bunch of tests, just start with what do I need to safely titrate the dose? And often that is the fasting, adding on perhaps bedtime to make sure that we're not missing the fact that there's a high bedtime blood sugar and that we're actually at a target insulin dose and we need to address the bedtime blood sugar. Also assessing how the patient ingests, because they start to take on some very interesting habits. Even though they were effectively taught how to appropriately dose their insulin, they will do some of the strangest things, like moving to giving their insulin in a site where they're actually now giving an intramuscular injection, such as using their forearm as an injection site, and there's no subcutaneous tissue there. We've heard stories about patients not properly dialing up their dose, and so they're not effectively delivering the amount of insulin. And it's important to have a return demonstration to make sure that patients are doing all of the steps of insulin therapy before we start always just going, well, you need more, you need more, you need more. So assessing their injection technique and where they're injecting their insulin is important. And last but not least, asking questions about adherence to insulin. So for example, instead of saying to someone, this is how you take your insulin, you might very gently say to someone, tell me how you take your insulin and what dose you're taking. And if the person is not comfortable in answering those questions, that might be a sign that they in fact are not actually taking their insulin. So you might want to explore that with them.
And that wraps up this two-part edition, with thanks again to Lori Berard. You can hear more podcasts and read the latest research news, expert opinion and practice tips at diabetes.medicineMatters.com.